Working It Out, a podcast show about diversity, equity, and inclusion in our workplaces, our communities, and our lives. A show where we put diversity and inclusion to work.
Got problems on the job, we're working it out. Workplace got you stressing, we're working it out. Yeah, we're working it out, working it out, working it out.
Welcome. I'm Dr. Vanessa Weaver, your host of Working It Out. On this episode, I'm proud to be joined by Dr. Margaret Larkins-Pettigrew. Dr. Pettigrew is the first Senior Vice President, Chief Clinical Diversity, Equity, and Inclusion Officer of Allegheny Health Network and Highmark Health. And that also includes their Enterprise Institute of Equitable Health. They're based in Pittsburgh, Pennsylvania. Dr. Pettigrew's deep passion for advancing medical health equities, particularly in the maternal space, and building programs to improve outcomes for women, people of color, vulnerable patients, and marginalized communities has been a common thread through her highly respected 30-year career. I was just telling her she is a phenomenal physician, leader. I mean, I can't imagine she's juggling all these balls at one time. And that brings us to the point that not only is she a OB/GYN physician, but she's a healthcare strategist, a medical practitioner. She champions diversity and inclusion. And then she's a professor of obstetrics and gynecology. Her work takes her on frequent regional and international lecture tours discussing women's health issues. So I want to say welcome, Dr. Larkins-Pettigrew.
Oh my goodness. Thank you so much, Dr. Weaver. It is such a pleasure to be here. I'm so excited about the opportunity to spend some time, chatting with you. So thank you for allowing me to just spend a few minutes with you today. So it's ditto. I really respect all the things that you are doing and, the hard work that you're putting in with all the things you do as well. So I'm just happy to be here. So thank you.
Well, Dr. Pettigrew, we know so much about, we've heard so much about health inequities, particularly as they impact women and people of color. In fact, the effort that you're leading with Allegheny Health Network really addresses those inequities and tries to look at solutions to deal with some of the systemic issues that repeat themselves and come up time and time again. But one of the areas, as we were talking, that I want to make sure we have a chance to talk about is this whole area of bias. And when we talk about health inequities, we often talk about those health inequities as they impact patients who are people of color, women. It could be the elderly. It could be whatever group there is a bias. But what struck me when I talked to you is that bias also extends to medical practitioners. I mean, to those doctors who are doctors of color or women or people who have a particular religious orientation and wearing a hijab or whatever, that we don't often think that doctors, in fact, experience bias. In fact, in a recent study, they found that 59% of doctors reported experience bias. And then 47% of doctors actually said they had patients who requested another physician to take care of them because of something around their appearance. It could be their gender, it could be their race, it could be what they're wearing. And I understand from you that another area that you've provided leadership in is really tackling this whole area of bias with physicians. Can you tell us a little bit about that?
Oh, absolutely. So we know that everybody is biased. We all have some bias. And sometimes bias is healthy, especially if you're in the protective place, that whole fight and flight situation. But in medicine, bias can really make a difference around the healthcare of patients. And it really does make a difference when it comes from the patient to the physician. We never think about that often, but across this country, this happens and has been happening for many, many years. When patients present to the hospital system, especially during this pandemic, when these frontline workers are working very hard to try to take care of these patients, And patients come in and they come in with this bias. They come in with attitudes and behaviors that come from their lived experiences, but they bring it to a place where there's no place for hate. I always say there's no place for hate at this healing place. Patients come into our situations across this country, but here in Allegheny Health Network as well. And they don't want certain people taken care of them. It's because of their personal characteristics. It could be anything from being an African American, being Jewish, being anything that they think does not belong in their circle because of their own lived experiences and the biases they bring to this space. The problem is, as an institution, hospital systems really work hard to build teams of experts to give patients the best care. And this is a place the bias in that space should not be tolerated at all for multiple reasons. First of all, we have expert teams that really want to make sure that their patients, our customers, are at the center of our universe. Mm-hmm. So patients should come in. This is a safety net for folks. Patients should come in wanting to make sure that they get the best care. So to make that request is absolutely not appropriate. But when they make that request, many times it has been accommodated. We've removed people from those teams. We've taken people who are the experts and shunned them and said, well, you can't be part of this team because the patient has the autonomy. Well, the patient doesn't have that autonomy in this space, because here at Allegheny Health Network, we've recognized that there should be no tolerance for that behavior here, because we want to make sure that that bias doesn't affect who we are, these great experts who are trying to give good care, and make sure the patient knows that we really care about them. So we have created a no tolerance policy, which is called the Refusal of Care policy. And I can chat a little bit about that if you want me to.
I would love to hear about that. Refusal of care.
So basically, we know that this exists and that it happens. And we really came to understand that it happens more often than we think. When there was one situation when I'm going to tell you a story, and this is where we're rounding, and the team is taking care of these patients who are COVID patients. They're gowning up every day. They're doing all the things they can. They're leaving their families to do this. But they're a diverse team. This is a team of people who are the physicians, the nurses. They're all mixed, ethnically and racially, and so we're talking to them, and they're talking about how great it is to be a team, trusting, working together, which is one of our core behaviors. And one of the African American nurses said to our team who was visiting and trying to encourage them, "I love my team. They take care of me." Because when patients come in and say they don't want me taking care of them because I'm Black, they take care of me because they take me off of the team and they just go in and they take care of those patients, right? And it struck me, and it struck the whole team who was around me. It's like, why should that ever happen? Why should she be removed as an expert, as someone who is giving at the front lines, especially during this time, removed from the team because of the bias of someone who's come here to get the best care they can, right?
Oh my goodness.
And so before that happened, it was just validation that we cannot tolerate that behavior. So we've created a policy. And that policy says that we're going to let you know as a patient that we don't tolerate that behavior, that we're going to give you the best care, but we're not going to separate our team. And so with that comes a lot of other things. You have to you have to educate and empower your team members to make sure that they can really, really comfortable in those uncomfortable spaces and talking about that. But the patients have to recognize that they are part of the center of our universe here. We want to give them the best care, and they cannot come to this space with any hate. And bias can reveal itself in hate, especially when you're in this space of healthcare. That hate can then result in health disparities.
So what happens? So with your particular refusal of care policy, and if a patient says, I don't want to be treated by that person because she has on a hijab, she's Muslim, and I'm a Christian, and I just can't allow that, then what happens?
We have done all the studies.
Dismissed?
We have all the studies that say that that's inappropriate. We have all the studies that say there's no reason why, certain people can't take care of other folks. So we know the data. And so we have an algorithm where the team leader has a conversation with the patient. Okay. And that conversation is, we want to give you the best care we can, and we can give you that best care with our entire team. What we can't tolerate is separating that team because of your own bias. So if you
call it out.
Yes, you call it out. You have to say, if you insist that we want to respect you, we want to respect what you believe. So if you insist that you don't want our team taking care of you, it's not just one. Remember, we're not singling this person out. It's the part of the team. So if you don't want our team taking care of you, we are really happy to discharge you so you can find care somewhere else, right?
Oh my.
And every time I've been in that situation in my long lifetime, the patient decides that they're going to stay and they're going to accept that care.
In fact, I was going to ask you, had that ever happened to you?
Oh, absolutely. Absolutely. I've been the supervisor and they say they don't want me taking care of me because I'm Black. And they say, I want to see the supervisor. I am the supervisor, so there's nowhere to turn here.
So how did that make you feel though? Does that eat you up inside?
Oh, those are pain points that I remember for life. And those are pain points that all of our teammates would remember too. All of the clinicians across this country that have experienced that really know that they should not have been separated from the team. Even our trainees, people are trying to be educated about how to be great caregivers. Many times they're trainees, residents, and medical students are asked by the patient to say I don't want them taking care of me. It's a journey. It is it's a place where we really have to be dedicated about empowering not only our teams to really step up and say and call that out, but that our patients recognize that is not a part of their healthcare. That in order for them to get good healthcare, then they have to make sure that they leave that bias at the door, because this is a place where it doesn't belong. Now, when we think about the market share and all, you worry, oh my God, we're going to lose these patients, right? What we found is that institutions that don't tolerate that are the ones that survive and do well, because the majority of folks, good folks, people who have good hearts, and everybody, I believe they have good spaces. They come back and they come and they say, I want to be at this institution because they'll take care of everybody. They're going to take care of me.
That's phenomenal.
That is the brand that we are.
You are so bold, because I know every hospital doesn't actually practice that. And it struck me when you were sharing this story in a client that we had in my firm, Alignment Strategies, and we were dealing with an accounting firm, and they sent a diverse team to this client, and they had some African Americans, and they had 2 African Americans, and they had a Latina on the team. And the client outright refused to have the team work on their project. And they, in fact, abided by the client's wishes and disbanded that team. And guess what? They wound up losing those 2 African Americans and the Latina left, because they felt if the organization didn't stand up for them, didn't advocate for them, then this really wasn't the place that they needed to be. So it's not only did the client not get in your case, like the best care, the patient didn't get the best care, but in this situation, the client didn't get the best team because of their biases.
Well, we don't want those teams walking out. We don't want those teams leaving. And it's all part of that belonging and feeling that I'm included.
And respected, for the investment that you make.
And for their expertise.
Absolutely. Well, let me, like I said, you have so many talents. You're an OBGYN. You have a practice where you deal with maternal care issues, particularly for women who have AIDS. You started your CEO or the president and program to educate global medical providers called Just One Door. Which stands for Women and Newborns, Diversity, Outreach, Opportunity, and Research. Oh my goodness. And then you're working with the Allegheny Health Network to really address diversity, equity, inclusions within their hospitals, within their Blue Cross Blue Shield divisions. I mean, I don't know where you have the time really to do a lot else of anything. But then you wrote this phenomenal autobiography titled The Colors of My Heart, Embracing My Blackness with History, Family, Fear, and Faith. Tell me a little bit about that book, and does that book convey your why? Why you chose this particular field of professional field and this practice and all of these other elements that come out of it.
Yes. First, I have to say that it is not just me. We work as a team. And I wouldn't be here if my team was not supporting me and doing all the other things that they needed to get done. So That it's a long journey of making sure diversity, equity, inclusion becomes the fabric of an institution, but it really does require that it has a very dedicated team that's going to do that, but it also requires leadership. And by me just being here, an institution means that they have great leadership because they saw the need. I'm the first, and they said, we've got to fix some of these things. We've got to take the journey. And that is a journey. It's not one-off. It's things that you have to do on the journey, the life journey of this institution, and how it becomes the best we can be through inclusion. So my book was written, I was writing it for years, but it is my memoir, and it really talks about where this all starts. I've done all of my DNA, my genetics, and gone back and really traced where I came from, which is so important because, when people say, what's in a name, I go through this, there's a lot in the name because people get their names from people who loved them, and people from their ancestry. And so, I wanted to figure out how I could continue to be in this space, because this space is not always a comfortable place to be. It can beat you down because you have so many people from so many different lived experiences. And as an African-American woman in this country, just waking up every day, it's a struggle, right? And so my journey.
As a doctor, you have this too. Everyday people like me and other folks, but here you are, big OBGYN, renowned in your field, and you still say, every day I had to wake up with the realities of being a Black female. Wow.
Yes. And so the book really reflects the history of how this country can see bias, can see disparities, can see the good, bad, and ugly, and how people are treated in this country. But at the end of the day, all of those folks who have all these pain points can be uplifted and can really make a difference in the spaces they're in and beyond. I was a little Black girl. I went through, I was born in the 50s. So I saw Martin Luther King die. I went through, all of the trauma of being told that I couldn't play with white children because I was Black. I went through so many of that, but I also lived through the drug wars. I went through seeing, the new Jim Crow, watching many of our young men go to jail. So I lived through all of that. But through all of that, I realized that I am so connected to the many colors of my heart, making sure that everybody who has anything to do with this issue of health disparities has to be involved. A white godmother who took care of me in the summertime, mixed marriages, etc. And the people I work with who I know, we can't do this without white folks at the table, right? When we talk about diversity, equity, inclusion, we clearly talk about the fact that they need to understand where we've come from. They, and I say white folks, Latinos, everybody needs to understand everyone's other lived experiences and history. So we can spend hours talking about, 400 years, but the issue is that if you don't understand it, you can't move to make sure you can resolve some of those issues that we are feeling right now, and we're faced right now as relates to disparities in not only healthcare, our wealth gap, transportation issues, all the social determinants of health that we are subjected to. So I'll stop there. So the book I want you to pick up, it's great. It's about, I'm a great granddaughter of Robert E. Lee's eldest brother, Sidney Lee. That shows you how complicated and how complex the lives of Black folks are in this country.
You mean the Robert E. Lee that was the president of the Confederacy?
Absolutely. My kids tell me don't tell anybody that, but that's part of my history. When I talk about the colors of my heart, I have to bring all that history into play because all that pain has allowed me to lift myself up and to really help other people be lifted up to be the best they can be.
Well, you talked about the social determinants of health disparities. What are a couple of those that really stand out for you?
So the issue of social determinants of health has to start back where we really have to address the political determinants of health, because the political determinants of health also results in the social determinants of life. And there's so many people in this country that have been in that space of being oppressed in multiple ways, that they need transportation. They don't have good food security. You've got women who are dying 3 times more, Black women dying 3 times more than white women. You have our babies that are dying 2 to 3 times more, Black babies, than white babies. If we decrease the death of Black babies, we decrease the death of white babies. We decrease the death of moms who are Black, we decrease the death of white babies. And what that tells you statistically is that we have to all be part of this issue of understanding bias, resolving bias, especially in healthcare, and really talking about the issues of structural racism. And, a couple of things that I'll give you one example as it relates to babies who are dying because of sleep accidents, right? Moms can't afford to buy cribs for their babies. Political determinants of health has resulted in social determinants of health, resulted in moms living in a situation they can't even afford to buy a crib for the baby. So what do we do about that? Because when babies are dying, people are rolling over on their babies. So we have things that we can do. We can give them baby boxes, right? We can give them these pack and plays. Identifying those needs and making sure we take care of those needs is one way that we can really backtrack and say, even though we have these political determinants of health that have resulted in these social terms of life, that we are going to make sure these folks who have been disenfranchised are lifted up and become a part of this productive society where they should be.
And so when you think about, we ask about the why, and you've given us so many examples of your why. But as you think about making these structural changes, you talked about structural racism. Mm-hmm. As you think about really making, say, a major change in structural racism in the next, say, 2 years in the health system, not just Allegheny, but in the national health system, what would that one structural change, what would be one of the most important ones that you could address that drives structural racism?
And that is leadership. Leadership has to learn to govern with a social justice lens. Leadership has to drop themselves into an uncomfortable situation and space where they're learning the history of how we got here. How did we get here? And how can we move beyond this to do better things, to make everything better? Businesses, or wherever. But it is the leadership of every organization, whether it be, a law firm, whatever organization it is the recognition of how we got here, understanding the history, the true history, recognizing it, acknowledging it, and then systematically and structurally think about how we change things within our own system, which then spills out into our communities. So it is that governance through leadership.
Well, when you talked about the leadership and the importance of them getting educated and understanding how we got here, it made me think of this whole debate around CRT.
Yes.
And the fact that many school systems are trying to ban it being taught. And in fact, it was a recent article, I think it was in the Wall Street Journal, that talked about this approach to even try to challenge CRT in the workplace, in terms of companies investing the resources to train their people about structural racism and how it impacts how they work day to day in teams. Have you run across that as a challenge? Leadership is important. I hear you said that's the one important element of structural racism that needs to be addressed. But is that hard to get leaders in companies and health systems to step back and invest that kind of time?
The political investment in CRT is really just another social construct. It is another way to keep us in this space of structural racism, keep us in this space of those who have and have not. Because if you don't face the reality of how we got here, if you don't understand that this country is built on structural racism and that it trickles through all of the things that we do, then you're comfortable sitting and saying, we don't need to change. We're great just like we are. The fear of losing what you have instead of making sure that others have opportunities as well is part of the CRT. And so, we don't talk about CRT here because critical race theory is not inside our bubble at this point. We have not had to confront that because we are on a journey to learn all we can. We don't feel in this institution that we cannot change and be the best and brand ourselves above others who really are not only thinking out the box, but making the box bigger, being the model that others can use to say, we can do this. So when we talk about, issues around racism and issues around the fact that it exists. We have too much information and too much data to say that we can't not move from here. But the purpose of making sure that we can move from here, or the strategic plan for moving from here, is to understand how we got here.
Well, I know we're running out of time. I could talk to you for hours. I mean, you're just such a phenomenal woman with such experience and depth of understanding about these issues and how they kind of intersect together. But I'd like to close our time today getting some more advice from you. And I would like to ask you, what would you suggest to a leader in an organization, someone who's committed to addressing structural racism, someone who is like really putting themselves out there to say that I'm going to live by the principles of a Dr. King? What would be the top 2 things you would suggest for them to do when they're being confronted with resistance?
To be courageous. Be courageous and show up with your authentic self. Let them see you. So the courageous part of it is being brave, because this is a space, we're in a war. We need to think about it that way. If we're going to change this country, if we're going to be about the business of making sure there is equality, we are confronting a war, a social war, a political war, one that is going to require courage. And courage with fear, because, we're going into some territories we haven't been before. I have lived through many George Floyds. And so the window for George Floyd and what he has done for us is phenomenal, but that window is going to close very quickly, which means we have to act very, very quickly to make sure that as a leader, people are stepping out with courage and they are stepping out with their authentic selves.
And why is that authentic self important? Why is the authentic, stepping out in your authentic self, why is that important?
Because knowing yourself, knowing, that where you've come from, understanding your own bias, understanding that you can be open and you can be criticized, but you can also be critical. It really is that growth that we have to make sure that we enter with, and that people around us, we found people around us who also show up with their authentic selves to say, let's, cut the crap. Let's talk about who we are. Let's talk about where we want to go. I want to see you and I want you to see me. And so that whole issue of showing that we are authentic self means that you can bring all your expertise into the room, all your wisdom, with courage.
Dr. Larkins-Pettigrew, I just want to thank you for spending time with me, our viewers, and our audience today, sharing your insights about structural racism and how that shows up in the healthcare system, social determinants of health and equity, and just your own personal and professional philosophy around the need to show up as leaders and change agents and being courageous in your authentic self. So again, thank you so very much. So on behalf of our Working It Out team and crew, I'm Dr. Vanessa Weaver, your host. I'm going to sign off, and I wish each of you a safe, productive, and what we call a be happy week. Goodbye.
Working It Out is brought to you by Alignment Strategies, a management consultancy with more than 3 decades of experience in diversity, equity and inclusion, and organizational development. To learn more, visit alignmentstrategies.com.
Got problems on the job, we're working it out. Workplace got you stressing, we're working it out. Yeah, we're working it out, working it out, working it out.